everybody, welcome to another episode of the Healthtech Pigeon podcast. Delighted to say that I've got two guests with me today, Jacob from Accurx and Howard, the founder of Whereby, helping Accurx do a load of telemedicine stuff, which we're going to be talking about relatively soon. Welcome, guys. How are you doing? Jacob, it's been a while. I'll start with you. A lot has happened probably since we last spoke, which was 5 or 6 years ago, episode 50 odd of the podcast, the Healthtech podcast. Like, it was before COVID, as if I spoke to you before COVID. Like, all this stuff has happened, all this stuff with Accurx. I don't know, man. Fill me in. What's been going on with you?
So yeah, lots happened. Still got the same mission. Fixing communication in healthcare. We see healthcare as a communication industry, a communication problem. That's where the value's added. That's where the things go wrong. That's what staff are doing all day, every day, making referrals, coordinating discharges, getting information to patients. Doing that more widely in the health system. So last time we spoke, it would have just been in the GP practices. Now we're doing it in acutes, in community, in mental health, in pharmacies, right across the health system. And loads of exciting things, that have happened and that are coming. Doing a lot more communication across the system, so not just with patients, but about patients. And very soon, you'll be able to communicate both with another organisation and another patient and a patient at the same time. So yeah, loads of cool things I'm sure we'll get onto.
Yeah, I mean, you guys were you were sort of like the darlings of that era, because you literally just came out just solving problems left, right, and centre. And man, primary care just loved you guys. Like, so many people in primary care just absolutely loved your product. You did something very clever, like putting it out and just giving access to just so many people that your user base just must have got very big very quickly. But then obviously, so that's just the beginning of the story, isn't it? You have to actually then solve a problem and give people a lot of joy and make it very sticky. But obviously it worked. And thinking about not only primary care now, thinking about secondary care, like it's what, over 100 years old outpatients. It could do with a bit of a reform, something along those lines.
Yes. So it's really hard to do something innovative in healthcare because the system pays for what it paid for last year. That's how budgets work. I remember talking to parts of the health system about messaging, probably about 6 years ago when we spoke. You can message your patients now and getting response. Oh, why do we need to? We could, what would we need to message them about? We just send them letters that they come in from appointments. Compared to today, where send 2 or 3 million messages a day. So we had to go direct to users. We had to minimize time to value. We had to get in their hand. Very, very common playbook outside of healthcare. It's how Dropbox grew. It's how Slack grew. It's how all this DocuSign grew. That hadn't been done before in healthcare. And so we went into COVID, I think in February 2020, we just celebrated hitting 50% of practices. I think we went into COVID with about 55% of GP practices using us. So still, people think, oh, everything happened, all our growth was during COVID. But actually, we had most practices before, but then that period was honestly the most exciting, emotional, exhausting few months. I think everyone remembers where they were in those few months, particularly people in the health system, of how do we, every day, what features can we ship today to make our users our users' lives better tomorrow? I remember crying in front of the team on multiple occasions. We had like 2 whole company stand-ups twice a day, being like, right, what features have we got to try out? These 3 things. Okay, who's got someone on support at the moment? Cool. Let's turn that feature on for them, get an answer. Okay, is it working? Right, let's turn it on for 10 more. Like, unbelievable pace that I don't think we'll ever be able to quite match. I think there's still a lot to learn and take from that. And one of the really cool examples of that was what we did right at the beginning with Whereby. So I remember vividly, end of February, talking to practices about this coronavirus thing. We've got a Facebook user group and putting a question on there, how can we help? And then being like, basically no response. So they're like, okay, there's nothing to do here. They're not that interested. A week later, talking to practices, being like, we are trying to find solutions, ways we can consult with patients without bringing them in. We but for example, we don't have any webcams and our browsers don't support video calls and all that. We are calling up patients to see if they've been in contact with someone who's had COVID, if they've been to, I think it was at the time, the Wuhan province in China, northern Italy, Iran, or the Costa del Palma 42 hotel in Mallorca were like the 4 hotspots. And like, there's got to be a better way to do this. So 5th of March, we had our team dinner, and Sequoia had published that article that probably lots of people remember around like Black Swan events and like COVID being that Black Swan event. And we were sitting there at dinner at Tramshed around the corner eating lots of chicken, being like, what can we do here? Coming in on Friday morning on the train in, emailing, I think it was just a cold contact form on the Whereby website to be like, can we just create an account or try something? And then we have in our office, this was our old office, we had like a mock GP desk with like sort of wobbly keyboard and a blue chair and a little screen and a slow computer that we test software. We're actually not as good as we used to be at testing stuff on there. But we're like, okay, the first thing that morning is like, can we make a video consultation work? Like, none of them have the hardware they need, so we're going to have to use a clinician's phone. Can we just SMS a link to a patient's phone and a clinician's phone? Try that. Like, okay, there's something here. Message some users who were talking to us the day before about this. Okay, let's try that with them. And they're like, okay, there's something here. We spoke to Whereby that afternoon, got access to the API. And then we're like, right, who's around this weekend? And I remember we did that show and tell town hall Friday afternoon. And there's a section of like, what's keeping us up at night? And our answer was, coronavirus. Are we doing enough? Question mark. Are we getting distracted by it? Question mark. So a bunch of people came in that weekend to build video consultations and to build like a questionnaire to ask patients if they, were at risk of having COVID. I couldn't help build that, so I went to panic buy MacBooks at the Apple store in Stratford because we had new joiners coming and we thought all the supply chains would freeze, which they did, but about 18 months later it turned out. And then Monday morning, we turned it on for about 50 practices and it worked. And then in the afternoon, we turned it on for 3,500 practices, which was the rest of our user base at the time. And then every graph went like that, good graphs and bad graphs. Usage, messages, SMS bill, loads on our server, like releases, everything. Support conversations went from like a couple of hundred a week to 3,000 a week. Everything went like that. But within a few weeks, we had 96% GP practices using us. So it was like a really, really intense time. And people often ask, is the stuff you built during COVID, will that last beyond COVID? And my answer is always, we didn't build anything like just for COVID. What COVID did was just accelerate all the stuff that needed to happen. Whether that's, the classic example I use is like before COVID, you'd go to GP and would say, right, you can send a document, we're working on sending a document electronically to a patient, and what you hear is risks. Where's the data stored? What if the patient doesn't see it? What if it goes to the wrong place? Obviously, there's lots of inherent risks in the incumbent system, sending paperless out in the post and all that. And then COVID happened, and it's like, well, if we can't send it electronically, what if they come in and get COVID? What if they come in and give someone COVID? What if they don't get their letter and they can't get their benefits payment or whatever it is? And so opportunity cost became risk is how I like to think of it. And that's what allowed, I think, not just in tech, just in, when you talk to people and they were like, oh, everyone was talking about 10 years of change in 10 days and all of that. I think it was because of that, opportunity cost became risk. I think that went pretty quickly. I don't think that lasted a year. So I think it was really those first 6 weeks, maybe 8 weeks that things reconfigured really fast. And then again with the vaccine program, which we got a lot of the vaccines. But yeah, it was a brilliant time, and that's when we started working with Whereby, and to go from an idea on Friday morning to something in 3,500 practices on Monday afternoon was pretty cool and stressful. Cool.
And Howard, welcome, by the way. What an introduction, yes, Jacob's just given you. And you're the guy that made that happen.
I'm having flashback.
Well, firstly, tell us a bit about yourself. Tell us a bit about the company. But I guess my first question beyond that would be: was this your first foray into healthcare? Were you running this platform outside of healthcare? And was this the first bit that you've done, or have you thought about healthcare? Like, what was it like receiving that request from Jacob at to perform at that sort of scale? But yeah, over to you, man.
Sure. Yeah. Thanks for having me. I mean, that was particularly intense trial by fire for sure, right? What Jacob is describing, and I'm sure we all went through a variety of that, in this industry, right? But the Whereby journey obviously started out, of course, in video calling, right? And the early sort of tenet had always been simplicity and a powerful experience, right? All at the same time, right? The fact that it's a Norwegian company, right, and the privacy was kind of built into our bone, and the fact that it was the first browser-based video calling experience, like even ahead of Google, ahead of everyone, right? I think that was sort of in our DNA from the very get-go, right? So as we kind of get going, right, obviously there are a lot of different use cases, right, from corporate meeting to distance learning to telehealth, right? There was a lot of usage, right? But I think COVID was obviously a watershed moment where so many of these telehealth use cases, right, like what Jacob was describing, right, was kind of landing, right, in our platform all at the same time, right? Like it was sort of the ultimate sort of a stress test, right, for our platform and our promise, right? Because we always said like, oh, get going, right, get going. One developer, 3-4 hours, you're up and running, right? So then when a few hundred telehealth company all knock on your door and say like, this is exactly what we need right now, right? And then it's going to roll out to millions of end patients in 72 hours. Can you guys scale? Right. I think that was we had to make sure that actually delivered, right? And I think it's not just COVID, right? I think what Jacob was saying that I really like, right, is we didn't build anything for COVID, right? Like they didn't, we didn't, right? The idea is that it was you get to a minimum viable experience because it's an emergency situation, but then you keep evolving it, right? I think the customizability of our platform allow innovators, right, like Accurx, right, to basically like, okay, we satisfied the immediate critical need. Now what, right? Like how do we keep making it better, right? How do we inject sort of our unique experience, right? Like all the way to now, right, like 2025, right, with all the AI stuff that's kind of happening, right? Essentially our promise kind of stayed the same, right? It's like, hey, whatever you're testing with AI, we think video, of course, is the most natural way to interact, right, for patient to provider, right, and whatever AI, however you define it, agents, like little background process, whatever, transcription, anything. We have our sort of capability. Feel free to bring your own, right? The idea is like it's easy, it's sort of painless to kind of put it together, and let's find out, right? Let's put it in front of a user really, really quickly, right, and get their feedback, and then we evolve from there, right? So I think it's been quite a ride.
Yeah, it sounds it. And it's quite funny. Like, you mentioned AI there, and there's so much obviously going on with generative AI now that everyone's focus seems to have gone so heavily towards generative AI and agents and LLM, like all these different models, right? Large agent models, like all the different stuff. And it's funny because speaking to you guys today about telemedicine and solving the problem through COVID, or at least going a long way to solve, I mean, what was an enormous problem, and doing whatever you could and clearly overcoming a lot of barriers to solve it in COVID. Telemedicine is a technology, let's not forget, that wasn't really around or deployed at scale before that. It's come in and now everyone just thinks it's normal. Everyone just thinks it's completely and utterly normal and the done thing, really. It's just not really turning heads whatsoever. And it's interesting, isn't it? Just how quickly something can innovate and be disruptive, but actually be completely sticky. And then the next generation people come along and it's always been there and everything's fine. I think the challenge then comes of defining or iterating this and defining what is excellence, and getting to a point where, you can be a video call platform, but you could also be a very specific for healthcare, very secure, very, very usable with utility across these different things, or this, that, and the other. So I'm interested from you, like what's the market like for this sort of thing now in healthcare? And I guess is there a conversation here about like what does excellence actually mean, and what does utility actually mean for providers like Accurx? Like what does that look like in telemedicine right now?
I think what's interesting, what we're seeing in the marketplace is that I think when the COVID emergency sort of receded, right? I think it was in a way sort of people were happy to sort of return to the world. But on the other hand, I think for a lot of telehealth company, sort of it became a moment of reckoning because you don't have this emergency situation that forces people to use telehealth, right? Now people have an option, right? Sort of in real world, go back to see their GP. Now they get a real choice, right? Like, did I use telemedicine because I really enjoy it? Or did I use telemedicine because I had to? And now I'm looking forward, right, to returning back to the way it was, right? And I think this is where you start seeing, telehealth platform that really focus on continue to evolve and add value, right? Kind of sort of moved ahead, right? And I think the platform that has sort of a minimum viable experience during an emergency and then stopped it there, right? Started to struggle, right? So I think that's kind of what we're seeing right now. Like the ones that are continue to focus on like, what else can we do, right? With a better integration with different system, with different kind of AI capability that's coming. How do we keep bringing that, right, in a way that actually adds value to both the physician as well as to the patient and to sort of like people who are looking at management at scale? Like, how do we keep adding more value through video and everything else, right? Like those are the ones that continue to evolve, right? And I think we've been really sort of learning and sort of evolving our capability to help that, right? And I think you're seeing, a company that sort of a little bit fell behind, right? When the COVID emergency let up, now is sort of like trying to play catch up, right? Because I think we internally within Whereby we call sort of the baseline experience that people now have of video calling in general or within telehealth, what we call kind of like the Brady Bunch experience, where like a video tile kind of stack in a grid. That's what video is. There's nothing beyond that, right? But then if you look at the really innovative players, like no, like there's so many things you can add in terms of the interaction itself, right? The value that generative AI can do in terms of, from transcription to be able to summarize data, to be able to play sort of catch up reminder, for patients, right? And they keep going from there to be able to interpret, sign languages to improve accessibility, to start talking about, real-time live translation, right? To basically expand, the healthcare option even further for different communities, right? Like the options are sort of endless, right? So I think players that have been thinking about that are having an amazing time, right? So I think that's kind of what the market looks like to us right now.
That's awesome. Do you think about this, Jacob, in terms of like productivity and like, I know productivity is something that you very much enjoy talking about, like layering these things on now and like telemedicine being this new sort of baseline of like, look, it's online, we can collect data, we can do lots of things. Is there like in some ways this is actually kind of better because we can layer these things on top and there's lots more that we can collect and there's lots more that we can improve? Like, is that something?
So I think coming out of COVID, there was this very binary debate, which was face-to-face good, video bad, video good, face-to-face bad. And, people trying to set targets. This percentage of appointments should be that, and this percentage of appointments should be that. And the reality is there are a bunch of consultations where face-to-face is the best. There are a bunch where video is the best, where telephone is the best, where messaging is the best. And what we try and do is offer staff and patients too that choice, and they're pretty good at deciding what's best. They're pretty good at figuring out, okay, actually I've got a rash on my arm and actually the best thing to do is send a picture. Actually this is physiotherapy appointment remotely, right? Well, a phone call's not going to work very well. Let's do a video call. Like staff and patients are really, really good at working that out. So I think we saw that that equilibrium find itself after COVID. I think that the danger with some of the AI applications is that we make things incrementally better and we completely miss the opportunity to redesign how healthcare is delivered. And what I mean by that is
the faster horses.
Exactly. And people really want faster horses. Like, why would you want a slow horse, right? If all you know is horses, Give me a faster horse any day. If you've got a system with 7.5 million open pathways and waiting lists, and you've got 100,000 staff vacancies and huge, pretty much every acute trust running in deficit, and people struggling to get a hold of their GP, you want your horses to be as fast as possible.
Yeah, you do.
What happens is like all the headspace and energy and attention goes into, for example, how do we make sure that 2% more patients show up for an appointment using machine learning to predict who's going to show up and who's not, rather than saying, hang on a sec, half the patients in follow-up don't actually need to be here. Let's address that. And that's the thing that really, really worries me. Is like, I think we're just starting to get past the point of amazing new technologies trying to find problems to actually, here are the really high value things to go after. But that's one of the things that worries me most, is like, how do we actually change the model of care delivery? Because if you look at, every health system, every economy in the world is facing this problem where the cost of healthcare is just exponentially growing. And, for lots of the reasons, everyone's familiar with, we're living longer, we're dying of more complex things. A lot of that is the success of modern medicine, because we have, all these treatments that weren't available before. And that means that people live to an age where they get multiple conditions. And we have better treatments that are available that are more expensive. But one of the big reasons is this thing called Balmore's cost disease, this idea that in sectors like healthcare, but also education and hairdressing and musicians, there are no productivity gains, because a 10-minute appointment with a doctor always has and always will take 10 minutes. And you get productivity gains in the rest of the economy, in manufacturing, in retail, in finance, which push up wages in the economy, and that disproportionately inflates costs in healthcare. And that's what we're seeing. That's why there was such a gap in pay between what junior doctors used to be earning and what they could afford today. That's why we're seeing the NHS under such financial strain. So, well, how do we square that? How do we bend that cost curve? We've got to find more productive ways of delivering healthcare. We've got to say that, for one, given healthcare workers' time, they are able to deliver more care. And so that when it comes to AI, I think that's the hard thing, is how do we not just tinker around the edges and rearrange the deck chairs? How do we actually say, now is the burning platform? Because I look at, we spoke about right at the start how COVID was this burning platform, and how nobody's ever changed that much and moved that fast as they did in March and April 2020. But I look at 7.5 million open pathways, and I think it's just as big a burning platform. Now, you don't turn on the news and see the Prime Minister on there at 5 p.m. every day, and you don't hear saying, will we have enough ventilators, and have to choose who goes on that sort of very sort of emotional, tangible, visible, people in full PPE and ICUs and things like that. But that's the scale of it today, the scale of how far behind our capacity is to our demand because of this old model is just as big as national emergency, but also just as big an opportunity to change things. And so we're trying to find ways that that you can increase that productivity, but they all come from. I said at the start, we see healthcare as a communication industry. The model of delivering care today was invented before the telephone. It was invented long before the internet, or before the telephone was in widespread use. Let's say, around the turn of around the 1900s. And there was actually, I walked past near our office. We walked to Bart's Hospital for a meeting, and I walked past this building, all boarded up, NHS building, and it said outpatient department. Oh, this is interesting. And carved into the brick relief was the London Hospital outpatient. So I was like, what is this building? I found online the floor plan of the building, and it was published in the Lancet as an example of optimal outpatient flow. And it looks exactly like every other outpatient department. You come in, there's a reception area, there's a massive waiting room in the middle, there's consulting rooms around the edge, and there's a pharmacy on the way out. Literally, I show it to people in the NHS today, and they're like, oh, that could be my outpatient department. It was published in the Lancet in 1903, and that's the model we're running today, right? Nye Bevan was 5 years old, Alexander Fleming just sort of finished medical or started medical school, I think. And what it means is that we say to patients, I'm going to order these tests and I'm going to book in an appointment in 3 months' time to discuss them, because we didn't have it. Used to have a way to send test results and discuss them. But that we now have a way to send test results and discuss them. We have had for decades, but the model hasn't caught up. It's really hard to do though. Like, people are very, healthcare's full of anxiety and risk, understandably, and it's hard to change these things, especially when no one's got any headspace.
It is. Well, that's one of the problems. I think the other problem is that the technology is moving so fast on that, particularly generative AI side, that any view of what healthcare could be reorganized into could legitimately change weekly, daily, monthly. Like, if you were to redesign healthcare around technology, like right now, you might go LLMs and agent models, and agents connect to agents, and this, that, and the other. And Howard, that's largely, some of the stuff that you were talking about, actually, about like gathering intelligence and then layering on these things, which absolutely can reorganize care and absolutely is and will be needed. And I'm almost certain, like, we're going to start seeing this soon. Ambient scribe listens, transcribes, agent orders the bloods and the x-rays, results come very quick, like which I'm sure is coming. But then you go, do you need consultations at all? Do you need and all these like out there questions of like, well, how what could healthcare actually be in these like crazy new worlds where we can't quite get it yet? And I think that's the issue, is that new world is quite intangible, because there's nobody setting our North Star in that, seemingly, because there's so many different groups. There's rural colleges, there's NHS organizations, there's political organizations, there's all that stuff in the center, there's arm's length bodies. Like, everyone's sort of got a say, and people will sort of like passive aggressively recommend things to each other in like government reports and responses to government reports and all this sort of stuff. But for me in healthcare, there's nobody that goes, actually, this is what we want. These are our rules. This is what we actually want to aim for. And I would love to see that, because I think it would really help inform a lot of this stuff. I think until then, it is going to be down to, frankly, like you guys at Whereby, to be like, look, we're layering this thing in. It's going to make your life easier. And everyone goes, oh, thank you. That's a bit more headspace. And with a bit more headspace and marginal gains, perhaps we're going to get to a point where people do actually have the headspace and are able to centralize around a vision. But I don't know who would come out and actually say it. I think it's difficult.
Well, I like what Jacob's saying, right? Like, it's like on one hand, right, I think everything that you're laying out, James, right, are all things absolutely worth thinking through and doing. Yet at the same time, I think, the things that you're talking about in terms of optimization and all that is sort of just barely scratching the surface. Like, I think we need crazier ideas, right, than even that, right, to kind of, in a way, demonstrate what's possible, right? I mean, like, I was reading about there's a small pilot in Japan that they're doing for seniors that are living in rural villages, right, where it's quite hard for physician to kind of get out to actually visit. So a researcher, what they're testing is they build this like little mobile game, right? Essentially, they are piloting in a couple of villages where like seniors, they just ask them like, hey, every day, when you're on your phone, like play this game. It's like, current events, some trivia stuff. That's all it is, right? It's like, hey, just please use this game. It's fun, right? Just play it every day. And essentially, they're sort of looking at engagement and sort of trying to use some of the algorithm that's kind of assessing sort of like potential cognitive decline, potential like sudden drop off engagement to prioritize sort of resource, right? And then there's like a telehealth element, or like, hey, if they see something that's dropping off, they will sort of proactively try to schedule like essentially a social worker to do like a video call to see, how are they doing, and then potentially accelerate, an in-person with telehealth, visit with their GP, right? So like, I mean, that's even not that crazy, right? But I think that's very different, right? Like that's thinking outside the box, right? So I think we need more of that, right?
Yeah, definitely. And you're right. It is out of the box stuff. And I remember speaking to Keith Grimes on my other podcast, and him just really challenging my thinking, going like, you're thinking too small. Like, what if you didn't have hospitals? what if everything was remote? What if everything was like all these things? And you're like, yeah, I having worked on the ground floor, like you're just so entrenched into, yes, but you have to have a consultation at a GP practice. And like, it's just the way, because it's been around for so long and it's just so entrenched in us, I guess.
I think the hard thing to do, but also the way to do it, and the reasons it is interesting and fun, and where the opportunity is to be able to have one eye on this future that people can't really believe yet, almost. I can't really see. And at the same time, be able to say, okay, what is the stepping stone? What are the stepping stones there? And what's the stepping stone we're going to implement today? And how do we make that feel like it's tangible and it brings immediate benefits and it's safe and it's, it doesn't need training and I can adopt it as an individual clinician. I don't need to like go and get a whole team or department or hospital on board, which, once you're doing that, it's, a lot harder to get decisions made. And that's what we're constantly trying to do. So if I think about the 10 plus years, and there's lots of ways of looking at it, but I think we can argue about how long, but it is inevitable that healthcare is going to be more asynchronous. It's what's happened in every other sector. More and more what would have been in appointments is going to happen through things like messaging. It's happening in retail, happening in finance. You don't have an online banking appointment, you just bank online. It's going to be more connected. So for as long as I can remember, I think as long as I've been alive, the system's been talking about integration. What does it mean? Integration, frontline staff in different providers working as one team. Simple as that. Try working as one team if you can only communicate with your colleagues by dictating a letter which may or may not arrive 2 weeks later. Try working as one team if to talk to your teammate, you've got to call a switchboard and then cross your fingers that they're not too busy, that they find a phone and respond to the bleep. It's impossible. You get nothing done. And the only reason stuff actually gets done in healthcare is because staff have an unbelievably unwavering commitment to their patients and making sure that things happen. Like in any other industry, it would just fall apart. Maybe education is probably also it's in a sort of similar vein how a lot of it works. So more integrated and then more automated, which is some of the stuff you're alluding to. Not just taking the notes, but these more agentic actions, more, that lets you do more prevention because you can, humans aren't great at prevention because we like immediate benefits and gains. But actually, we've spent the last 50 plus years building all this evidence and systematic reviews on how to manage all of these things. If you've got type 2 diabetes, how exactly do you manage it? And there's thousands and thousands of papers on that. And it's really, really simple stuff. Get your eyes checked, get your kidneys checked, get your feet checked, get your blood pressure checked. Only 50% of patients get it. And we've been trying to do it with guidelines and protocols and leaderboards and payment and all this stuff. And maybe the way we're going to do it is to automate it. And to automate it and say, okay, you've got type 2 diabetes and these are the things you're going to get and it's all automated. And so I think those are long term the three big shifts. The challenge is, okay, what's the little slice of that we can give people today that makes it feel real and adds value?
So this is the thing, and this, before we move on to actually talk about the news, this is the final point I'll make. There is nothing more alienating to a clinician when you start talking about generative AI and agent models doing all of this stuff automatic. There is nothing more alienating than just saying that to a jobbing clinician who today in their hospital, the one printer that worked ran out of ink and the entire hospital fell to its knees. And you're like, yes, I probably shouldn't be talking about AI and robots, like autonomously, doing everything and taking your job. It's definitely not the case in the immediate future. But you're right, Jacob, because I think knowing how to actually sell that in and knowing how to actually decide what that slice is to start getting some momentum and building some hope, because it sucks on the ground floor. It sucks. It's so hard. But actually, if you can start to get a bit of momentum and give people that hope, it's a sort of thing coming back to telemedicine, telemedicine was pie in the sky at one point. Telemedicine was, that'll never work because you can't put a hand on someone's pulse and you can't put a hand on their abdomen. That's ridiculous. Like, people say this stuff all the time for new technologies, and every new technology that's ever come in any sector has faced some of this at some point.
That's true, but also there are a lot of the things that people say are pie in the sky that turn out to be pie in the sky. So, I'm not saying like our advances will be, but I think it's not quite as just the case that people don't see it now, but they will at some point.
Fair. Maybe Tesla robots won't be walking around hospitals and doing everything so soon as I'd potentially hope or not hope.
We get all the team to go out to visit the front line, visit practices, visit hospitals, and like even hundreds of times, never cease to every time come back with a fire hose of learnings. Like we've done this whole big rebuild of loads of parts of our product, but loads of investment in the UI and like made it much more modern, much more slick, and you go out there and you're like, oh, we've done the modern thing of like you can't actually see the scroll bar because everyone uses the track. No, actually, loads of healthcare staff don't use the scroll wheel, and like, where's the bar to drag? So, like, that's we've got really wide distribution in technical literacy. Obviously, that's a generational thing, and that's shifting. But yeah, I definitely agree with you on like we can't alienate them too much. We've got to give value today.
But I think, like, as technologists, right? I think we got to make sure that we love the technology for sure, right? But we have to remind ourselves like we love the problem more, right? I think when we're talking about technology, talking about generative AI, people's eyes glaze over, right? Then you talk about what it can actually do for you, what it can do for the patient experience, right? Then I think people are interested, right? Like, I don't care about generative AI per se. I care about how does this make my life better? Why should I care, right? I think that's a part, I think, in allowing the hype around AI, right? Or really any technology, right? Like, I think that the user get lost in a lot of the techno mumbo jumbo, right? The techno jargon, right? Who cares,
Absolutely.
Right? It's about how does it make things better, right?
Yeah, care that my notes are written automatically. I don't have to spend 5 minutes doing it after every patient. I actually don't care what's under the hood. I
don't care how it's done, context. Right? Like, it could be magical gnomes for all I care. Like, as long as it is done,
as long as it's safe,
right?
as long as it's effective, right? As long as it doesn't miss red flags, as long as it helps the next person down the chain, like as long as all these things, and if we can prove those things, yeah, don't really care what's under the hood. I think we saw this in blockchain, didn't we? Like, everyone's talking about blockchain all the time. Nobody cares. Like, literally nobody cares. Absolutely nobody cares. What I'm saying.
but the faster horses thing, like, yes, clinicians care about their notes being written, and so they save 5 minutes. But saving 5 minutes of an appointment that didn't need to happen isn't really saving 5 minutes. So and I think that's the thing and I get why ambient scribe is clearly going to take off because it's so tangible and it's just so much easier to implement than a lot of other things. You don't have to change clinical pathways. You can do it, individual by individual. You don't have to get sort of everyone on board at the same time. But I think those are a real big shame would be we do a load of optimization on a really outdated care model, and then in 5 years' time or 8 years, or whatever it is, 3 years' time, we start to hit the same problems.
Yeah, I hear you. Because it can happen even quicker than that because you get supply-based demand. If you build a brand new motorway, a brand new highway, everyone just buys a second car because there's no traffic, and all of a sudden you're back to square one in 6 months. Everywhere's blocked again. So this is the thing, like ambient scribes that can write all your notes for you. Perhaps we just spend longer in the consultation a little bit. And I know some of these ambient scribe companies are actually doing this research to see like what does actually us coming in change about the clinical consultation the other way. And I think that's actually very smart research. I know Dom from Tortoise has talked about him in doing that research as well academically, because I think that's a really, really important point, Jacob, is that if we're optimizing an old model, that we get super fast horses, but we've got 1 million horses. We didn't need them. We only needed 5, because we can actually change the system. But you're right. Yeah, if we're just enabling so many more appointments that also don't need to happen, we're going to be worse than back at square one, I guess.
What I find fascinating when you go in a hospital is there's like calcification of layer upon layer of why do we do this? Not that efficient thing. Oh, it's to prevent an even more inefficient thing.
Yeah, it's great.
To prevent an even more inefficient thing.
Yeah, it's a great word, by the way, because also I've heard it described as ossified, this like this gradual sort of hardening and shrinking and brittle nature of, and that it sort of captures it beautifully, like the calcification of it. Yeah, completely. It's yeah, we need a new system. Just don't know exactly who's going to point us in that direction and define that. But let's talk about some news. All right, we got here in the end. First story today, patient portals top digital health use in older adults, survey finds. So basically, survey's been done and patient portals are super popular, basically, is what I got from this. The other thing that I actually want to point out from this article is that non-Hispanic Black race and ethnicity was actually... they mistrusted the system to such a degree that it was significant how little they used patient portals and other types, access other types of technology in healthcare. And us at SomX, we've all done, Malone, who's the guy who wrote Mind the Gap, the dermatology for black skin book. He's got a course out on the history of black race and ethnicity in healthcare, and talks all about the mistrust of that group and where it's come from, certain experiments that we've done, certain like HeLa cells, which I did not know about before, shamefully, cells taken out of someone then used broadly in pharma without people's knowledge, and all these things have contributed to a great mistrust in the health system, which has actually persisted through generations, which I think and persistently think is fascinating. But I'm interested in what you guys think about this. So patient portals, super popular apparently.
So now I'm going to hold my hands up. I still don't understand what fully a patient portal is. Is it just anything that's to do with health? In some cases, it's seeing when your appointments are and changing them. Some cases, it's seeing a test result. Some cases, messaging. Some cases, it's ordering prescriptions. Some cases, it's video consultation.
I think it could be any of those, but my view on it is that it points to the patient being empowered to do it, whatever it is. I think that for me is what makes it would make it popular and would make sense. So that's kind of how I would define it, that they are enabled to log into something to see their results, diagnostics, tests, whatever it is.
Well, I think that it makes sense that they're going to be the most, well, what's the headline here? The most popular digital health product, right? It's not saying you're using it more than WhatsApp or Amazon or whatever else. Because what other digital health stuff is there to use if the patient portal is everything? But this broader point on empowerment, I agree with, because going back to our earlier conversation, where are things going in 10 plus years' time? There are a bunch of things that are inevitable, right? People will get sick. Medical science will advance. I think one of them is patients will want to be more and more empowered, and that's only continued, throughout history, particularly the last 2 decades, and will only continue. So I definitely agree with and see that. But I think that the point I was getting at with my initial question is, I think there's such a wide distribution in functionality and what's in the patient portal. And some of that's technical functionality. Some of that is like what the provider turns on. Like you can have a patient portal that lets you book appointments, but if there aren't any appointments made available, you can't book appointments. So I think that's where there's a wide distribution. But yeah, absolutely, we should be empowering patients. And again, faster horses, right? So one of the things we've found is that even like long before COVID, there was a big push on patients being able to book GP appointments online. And so the functionality was rolled out, and it was put in the patient access app and by EMIS and through a number of other channels that patients can book online. But what happened is practices didn't like turning those appointments on, or they put very few on, because patients would just book appointments, often sometimes for the wrong thing. Particularly if you have very specific appointments for phlebotomy or for smear tests or for diabetes reviews. Like you only want people who are eligible and need diabetes review to book that. So it's another good example of like COVID legacy, right? During COVID, we built something for vaccine booking, which was inviting a patient to book a specific vaccine, like their first dose of the AstraZeneca vaccine, for example. But then how we've generalized that coming out of COVID is inviting patients to book for an appointment. And actually a specific type of appointment, what we found is in general practice, that's now way more popular, is let a patient get in touch, triage them, work out the most appropriate modality. Maybe you can deal with their messaging, maybe it's going to be a video consult, maybe it'll be a phone call. And then if they need an appointment, invite them to book one. So it's a very subtle but a very important distinction between like patients can just go in and book stuff, which is more popular in like US and France because every appointment is revenue for in primary care. And in secondary care, there isn't the same capacity constraint as there is here. But that's what we've started to find is that actually what patients need to be able to do is get in touch and then be triaged. So I guess the broader point I make is I think patient portals they're in like the foothills, and we're finding out how should they actually work. Big thing obviously we're pushing on is messaging being in patient portals that things like that.
Yeah, I think from my perspective, I went through that news item as well, right? They talk about the popularity among older adults for patient portal number 1. And I think is a telehealth number 2, and mobile application number 3, which is great, right? I think all those things, of course, theoretically should provide, like what Jacob said, right, more control, right, and put that in patient's hand. At least I hope so, because just because people use something doesn't mean they like it. Doesn't mean that they have been given an option to do something else, right? It could be that people are using patient portal because that's where they're being forced to go to, right? So I think there's a part I would love to kind of have that study go a little bit deeper into, like, do they actually enjoy it? Do they actually find benefit? Do they actually, have, more control? Because, the nightmarish scenario, right, is that patients are being directed to these less personal, interaction point because it saves the organization time and resource, and it doesn't necessarily provide a better experience and more control, right? So I think there's layers of nuance to it, right? But I think, it is, I mean, on the other hand, right, I'm also thinking about it, it's like, patient portal is often, right, the homepage, right, for accessing healthcare. So in a way, of course, it gets the most usage, right? Because it is literally the starting point. Like, you have to start there, right? So I think, there it's tantalizing, I think, this news article, but I think it needs to be dig a lot deeper into, like, do they want to use it? What do they then do, right? Is it messaging? Is it accessing telehealth because they want to? And what do they get out of it, right? So I think I want to know more, right? Because I think otherwise we run the danger of, like, assuming, like, more patient portal usage is, of course, better and better thing, right? And I think before everyone rushed to commit that, right? It dig deeper. I think that's kind of what goes through my mind.
Yeah, clearly lots more for us to figure out on this. I think, as you say, we don't quite know what we might mean by patient portal, but similarly, you raise a good point, Howard, about it's not just enough to sort of binary say that you do these things anymore. In the same way that we talked about telemedicine earlier, I can't remember whether we're recording or not, but saying that you can say that you do telemedicine, but there are actually shades of how well you do that based on features, based on lots of different things. And so it's incredibly important to not only talk about, oh, yeah, we've got a patient portal. I think actually it's probably pertinent to media. It's pertinent to all of us in the space to question, what does that mean? What does it look like? How good is it? And for us to actually do that work, to start defining this stuff, because I think we're far beyond now. Oh, we have a patient portal. Oh, we have a companion app. Oh, we have this, we have that. There's actually so much about the quality of it that makes all the difference. So I think that's probably the conclusion here. So our second story today, this is super interesting. So one of the contributors at Forbes, someone called Spencer Dawn, they've written an article, AI threatens to further erode physician autonomy. Now, this is really interesting. So Spencer Dawn is a gastroenterologist, covers healthcare and technology for Forbes, and has written this really interesting piece that brought up not a new concept, but a concept I certainly hadn't thought about in this way before, that whilst AI will be taking away certain administrative burdens and lots of things that we want it to take away, It's asking the question and providing a lot of evidence for the fact that might it also erode physician autonomy, leave people more dissatisfied, and actually contribute to increased burnout, and how AI is actually going to further this trend and accelerate that potentially, and lays out a very good case for it, I must say. Howard, Jacob, any thoughts on this one?
Yeah, I think it could happen, right? Because at the end of the day, right, AI is just the latest technology, right? Technology is a tool, right? So I think depends on the intention behind, the how you deploy the technology, right? It could be for good and for evil, right? So I think that's something that we must be very, very mindful for. Like, what are we doing it for, right? Like, if you're going to use it to, take away, physicians, like rightfully earned judgment call, right, at the expense of optimizing for a few pounds here and there, right? Like, you don't want to, like, that's going to be bad, right?
Well, this is it, and this is what I talk about with this North Star vision thing, because what are the components that make people feel the autonomy? What are the components that might contribute to that being eroded and degraded away? Perhaps we should define those. Perhaps we should figure out what it is about being a clinician. Is it the practice of empathy that actually provides people that job satisfaction? Is it the art of medicine, inverted commas, often talks about, the diagnostic challenge and the ability to kind of see these things based on algorithm in your head? If part of that is leading to satisfaction, well, how do we optimize for that with AI as well? But again, it's this vision thing. I just think we're missing, and it's going to open up these discussions, definitely.
There is a world in which AI is deployed in a way that not just erodes physician autonomy, but erodes morale, leads to more burnout, and so on. And there is also a way in which the exact opposite is true. And I think AI is such a broad, even the technology is broad before you get into the use cases, before you get into the implementation, all of that. And what we know from kind of every other technological advance through history is there was a point we said, right, industrialization of agriculture, of factories, of professional services, that is going to lead to mass unemployment and these things. And what we find in general, in every case, is that the economies are very good at creating more higher skilled jobs that are a better use of human capability. I'm optimistic, and I think that's, we will find ways to implement AI that do that. Like, I don't think most clinicians love clicking through loads and loads of pop-ups to try and prescribe, a paracetamol. I don't think most clinicians love, filling in multi-page forms and then trying to get hold of someone on the phone to make a referral and coordinate. Like, they don't enjoy that. So if we can free them up from that grunt work and let them spend time doing really what I see is the basis of what we want, medicine to be, of building relationships with patients, helping understand their goals, helping them achieve those goals. I think for so many clinicians today, that's actually quite hard to imagine because they're under so much pressure because of all the grunt work and the pressure on them. Now, I think what is true is that with wider autonomy, you have a wider distribution of outcomes, which means you will get some more superstar performance, but you also get some more poor performance. And so we need to find a way of using technology that lets the innovators come up with really great ways of delivering care. But then we do need a way of standardizing that and saying, okay, actually, this is the best way to manage that pathway. And we're going to encode some of that into how our algorithms steer consultations and actions and so on to standardize best practice, because actually there are a lot of cases where autonomy can be very, very good, is very, very important, but also there are a lot of basics that aren't happening today, and if we can use systems to automate that, that's going to be a lot better for patients. But what we're seeing, what we're hearing initially from clinicians using things like ambient scribes is they can spend more time looking the patient in the eye, patient has a better experience because they have to think out loud and say, "Oh, I'm going to look in your ears, and actually, your right eardrum looks fine to me," rather than just not saying anything and scrolling some notes in. And so I'm pretty confident we'll find ways to use it that enhance that. Again, this all goes back to the better we get a medicine, the longer people are going to live. They will get sick with other things, more complex things. There will be no limit of problems to solve. One of the things that is also true in 10 years' time is like people will keep getting sick. So I think there's so much to do, but we want to liberate humans from a lot of the grunt work.
I think one of the things this article does miss as well is the notion of redefining what the clinician actually does. In reading this article, I think it sort of sets out a world where these sorts of things are taken care of by AI, but then AI is also watching you more as an employee, and you feel like the walls are closing in because there's just AI literally everywhere, and you feel boxed in and watched, and that's going to contribute to burnout and all those different things. I think that sort of ignores a world where AI is trusted more in that diagnostic space to allow the humans to then practice as human beings, as care navigators through the system, as communicators, as putting a hand on you and telling you everything's going to be okay, because we know that optimal healthcare might be the perfect diagnosis and the perfect treatment, but optimal healthcare is also the optimal patient experience. And the biggest driver of patient experience is the feeling of empathy. And actually, when patients feel like they've had an empathic experience through the healthcare system, their hospital stay is longer, they get better quicker, they report that they had a better time. Like all of these, you get better history taking, by the way, when you have an increased amount of empathy felt in the conversation. So the history's better, therefore the diagnosis is better, all these things. And so we do know that the human is best placed in a human role. And I think it's less about expecting humans of the future to memorize the cheese and onion book that we all meant to memorize as clinicians, and know all the pathways and know all the intricacies of the rare presentations of blah, blah, blah. We no longer need to burden ourselves with that. And actually, I think it opens up the world where we really go deep on what is actually the perfect interaction with the healthcare system driven by humans, and actually looking at that incredibly academically. I think that is a world that is opened up. And I think, well, my suspicion would be that would override any feeling of a lack of autonomy, because actually people are no longer selected into clinical roles on their ability to memorize facts. They're selected into healthcare based on how good are you with AI as your sidekick to deliver a fantastic experience for those people coming through, because AI is going to give you the perfect diagnosis and treatment. It's up to you to get the perfect history. And actually we go super academic on that, for example. And what is it about your body language, your facial expressions, your words that elicit the greatest history? Well, actually, then we talk about empathy. And as I've talked about here before, there's 3 types of empathy, and AI is very good at faking one of them. But actually, like all these different things, and perhaps we go really deep on that side of things, and we start to make healthcare just feel better for people. And perhaps that is the marginal gain. I don't know, but allowing us all to do that would be a start. So I'm less worried. I'm similar to you, Jacob. I'm less worried about a lack of autonomy being felt at scale in future. I think it's more about in an iterative way, as this technology comes in and starts to do these things, redefining and consciously actually checking in with ourselves in the healthcare space and redefining what skills does a clinician need in this world? What do we actually want those people to be? Yeah, I guess optimizing for that.
The metaphor that we've been using at Whereby, right, when we talk about sort of the interaction between human and these type of AI assistant agents, whatever you want to call them, right? Like the metaphor being using is we will like the clinician, right, to essentially be more like an orchestral conductor, right? The idea is that right? Like you're ultimately responsible for the experience of the audience, the patient, right? But then having sort of these finely tuned, responsive, individual, AI or human team member players, right? That assemble and deliver the experience, right? Like maybe that is the right way to think about in terms of enabling the clinician to do that, right? To be able to sort of deliver the art of care, art of medicine, right? And then you are sort of responsible for the orchestral symphony, right? Like that's kind of the metaphor we're using, and it seems to line up, but I think it's pretty far from where things are today. But that's kind of how we've been kind of visualizing it.
I love this. So we've got a different metaphor for automation. And we talk about driverless cars. We say, right, we're actually not trying to build a driverless car. We think the human is going to stay in the driving seat and make the ultimate decisions and be able to override at any point. But what automation is going to do, and what we're trying to do, is build the sat nav, the lane departure warning, the cruise control that's adaptive and keeps, and all the stuff that makes driving more comfortable and safer. The parking sensors. Now, when I'm driving a long distance and I start to drift lane and the car like beeps or keeps me in lane, I'm not like, damn automation, I want my autonomy back. I'm like, oh, good. It's like I don't want to be like, having to. It makes things more comfortable and safer. And so that's how I look at things. Like AI automation is going to be assistive, but for all the reasons you described, like healthcare is always going to be human, and you can have two patients physiologically identical that want completely different things, and you can have AI that is 100% sensitive and specific at what it's at, so giving recommendations, but if a human doesn't like what it hears, it's going to want to hear it from a human. I've clocked this years ago using the Babylon symptom checker years ago, and it said, "Oh, this is just self-limiting," something like that. And I was like, "Okay, it said that, but I want to hear it from a human." Maybe that'll shift over time, but I think. And then the other problem, which is exactly the same as the driverless car problem, is like no one has worked out who holds the risk when the system makes the right decision, but because of statistics, sometimes that still leads to a bad outcome, right? If you treated every fever as sepsis, we'd have a load of problems, and we'd have antimicrobial resistance, a load of other stuff. But very occasionally it will be, and we have well understood systems in human medicine of how that is handled, and did a clinician do what was in line with the guidelines, what was in line with what other clinicians would have done. But we haven't worked out who holds the liability, who holds the indemnity when that decision comes from a machine. And so what in turn happens is all the little dials around, do we want to be more risk-taking or risk-avoidant, and risk-taking and therefore more efficient, get dialed right up, and you end up with the send everyone to A&E problem, because you're trying to minimize risk.
Awesome. Well, guys, listen, we've put the world to rights a little bit here, but yeah, plenty on AI as always on this podcast. The whole news is just like bombarded with it at the minute, so we have to talk about it. But listen, it's been really interesting actually. I mean, as I said at the start, telemedicine's been one of those things that like it solved a massive problem, and then everyone just got used to it so incredibly quickly. But clearly, there's a real role for defining what excellence is, the presence of new technologies being worked in, what that means for reorganizing care. There's clearly plenty that you guys have to think about and riff on at Whereby, and how you're going to do this in healthcare and all that sort of stuff. And Jacob, yeah, pleasure to catch up, man. It's been a while. Let's not leave it 6 years next time. I need to get you back on the other one and give you a bit more airtime on the other one, but I'll be in touch about that. Before I let you guys go, just give me one quick thing. What's something that you guys are excited about? Whether that's like something that you're building, something in the space, something that you're looking forward to. I don't know. Like what's one thing that's exciting you at the minute?
One of the things that's really kind of exciting for what we're working on at Whereby, right? It's just the ability to actually allow different telehealth platform to sort of bring their own integration, bring their own AI agents directly into the video platform, right? I think everyone right now is sort of pushing their own. And I think whereby we're taking a sort of like, we're not AI first. I mean, that's almost a cliche. Like everyone's talking how they're AI first. We're just AI ready, right? Like bring your own, right? I think everyone has a different point of view. Everybody's looking to experiment with different things. Bring it, right? Essentially, I think that's the part that we have been getting really good reception, right? Which is like, try it. This is, I think video is where, the most natural interaction can happen, right? And I think this is the perfect sort of a playground, right? For, patients and clinician to see like, what does AI actually do for them, right? In a way that requires very little sort of like hard integration, right? So I think that part has been pretty exciting for us right now. I think we're just at the beginning of that.
Awesome. Thank you, Howard. Jacob, just to let you know, his audio is gone, so he's going to give his on his next episode of my other podcast. So I'm going to direct you guys to that episode. I'm going to message him after this. But listen, guys, absolute pleasure. Thank you so much for coming on. We're going to stick all the links to everything you guys do in the description of this episode. And yeah, this has been Healthtech Pigeon for another week. So if you want to grab the stories that we talked about today, you can go to healthtech.com. You can get that newsletter, hit your inbox every Sunday. Otherwise, we'll be back next week with more stories, more guests, more fun. See you next week.